Recorded. So, just to give you a little bit overview about, there is so many, you were asking, what do we need to memorize? So, in emergency medicine, in the starting part where there is primary survey and then there is secondary survey. So, in that one, you need to read and keep that thing in your mind. Like, if any questions can be approached in different way, you know how to write and what to write. Okay, that's mainly for that. But what exactly and actually you have to read, but when you go to emergency medicine or any kind of topic, you need to know the topic name, what you are reading. Then you need to know their signs and symptoms. Why sign and symptoms? That can help you to make the diagnosis. Or if they give you diagnosis and asking for some particular signs or some particular symptoms, like in appendicitis, what are the symptoms that you will see, or what are the signs that you will see? So if you know appendicitis, then you will know SWAS sign or rebound tenderness. That's what you need to know. Okay. Then what you need to do is investigation, especially in investigation that you need to do is what is gold standard investigation. What is the one main underlying investigation that you would like to do for this person particularly? Only one investigation. And like, I don't think so because the exams is not for like the extensive questions, only MCQs. So they would preferably ask you to go for the investigation that is mainly for that particular thing, like doing chest x-ray for finding out pneumonia, right? So what is the main underlying investigation? Okay, that is very, very important, knowing that one. Like basically, how for pancreatitis we go for lipase. That's more important than doing anything else to find out if he has this or not. Then on the basis of it, like you did investigation, then comes to the treatment. So if we are going to do family medicine, then need to know the basic investigations, like if a patient comes for otitis media, then you need to give what kind of treatment, especially in peds. There is different treatment, like you need to know what exactly the amoxicillin, ceftriaxone, or whatever the antibiotics that you are going to give for this patient. Okay, just writing antibiotics or knowing antibiotics is not enough. You need to know particularly which antibiotic that you are going to give. So my main point of view, like in this part, is basically when you're doing any kind of topic, like hemorrhoids, right? So you need to know the signs and symptoms. You need to know how to make the diagnosis. You need to know if there is any picture, like any chest X-ray or any specific picture, how does it look like? Then comes to the investigation, which is the one particular investigation that you would like to do. And obviously if you can read the other investigations, that's good to do that. Then like that's the main memorizing part. Then comes to the investigate like treatment, which is the one particular treatment you would like to do at this point as a family medicine and as an emergency medicine, or as an emergency physician. So things are approached in a different way, like asthma. If it comes in an emergency, it's a different approach. If it comes in a family medicine, it's a different approach. Okay. So these are the things that you need to know. In this exam, particularly, they like or they want you to know how you're going to approach that patient ethically, physically, or like physically means like knowing as you are a family physician, you are an emergency physician. I mean, whoever is in practice right now, I understand your knowledge would more than enough for you to pass the exam. What you need to work on is how to encounter the questions, especially when you're working as an is in Canada. So if possible, you guys can go and approach some opportunities like observerships in some clinics. Go do it for 2, 3, 4, 5 whatever days, for 1 or 2 hours, whatever it is. Okay, that will help you to find out how the doctor here in Canada works. Okay, so maybe working as an observership is nothing. You don't need anything. You don't need to like do anything. And how you can find observerships? You need to go to clinics. If it's good, if it belongs to your ethnicity. Like if you're Pakistani, go to some clinic where there is Pakistani working. If you are an Indian, go to somewhere, you can just always use like, oh, I am a new person here. I want to explore. I'm writing my exams. Can I do observership? And they would happily take you in. Observership is nothing. You just have to stand there, observe them. You don't have to particularly need any kind of degree or anything for that. Okay, even you can find observerships in hospitals too. So I would rather suggest you looking for those things in your spare time if possible, if you guys can do that. That can also help you to figure out how you're going to write down the exams too. Let's suppose if your exam is near, so main focus on how you are going to do the approach of the exam. If you are a working physician, even if you're not a working physician. Now, since we already did emergency medicine, I hope you guys read something from there and you have, like, gone through that one, did some MCQs, and you have an idea where we are going and how we are going. So now coming back to general surgery, why I'm reading everything from here, so you have an idea. It's not like whatever I'm reading, you have to memorize everything. You need to memorize only selective things from there. Reading them, it means you have to keep those things back of your head. If it's asked to you in MCQs in either way, you know what it is. Like, cervical collar, we were talking about cervical collar, right? So you need to know in which scenario and what kind of scenario will come. Then I have to write down the, it's like making a concept about how you're going to choose your answers. Because when it comes to MCQs, their MCQs is quite tricky, because like, like how it is, like they can write down in MCQs like diverticular disease, diverticulosis, diverticulitis. If you don't know the exact difference between them, you will not be able to choose what the answer is. And your exam is mainly based on MCQs. Okay, so that's why the concepts are more important than your knowledge. I hope that makes sense. Although in some part knowledge will be tested too, like in obstetric parts, they usually like to test your knowledge. In gynae part, they used to like to test your knowledge, but in emergency and family, they like to test your, how you're approaching the case. Now coming to general surgery and thoracic surgery, in this topic, I will let you know. So in this one, you can just, if you have time, you can read these all things. Otherwise, it's not that crazy important. These all are anatomy. Differential diagnosis, you can read it. All you have to do, and then most important things, the sidebar, you have to read the sidebars. Sidebars are very, very important, especially in Toronto notes. Any kind of sidebars, it's actually been tested in the exams, like other than anatomy part. Like here, this is arterial blood supply, so you don't need to know the arterial blood supply. You are not going to be tested for anatomy. Okay, but when it comes to here, if you can see, in all patient processing with an acute abdominal pain, order the following. So these are all the blood works that you have to do. But it does not mean, like, it means, let's suppose if 30 years old female comes to you with abdominal pain, what is the main test that you would like to do in this patient? Beta HCG. Before doing anything else, you would like to rule out if that this patient has, pregnancy or not, then moving on to anything else. But if it's a 40 years old male, he's homeless, he's alcoholic, and he's coming to you with abdominal pain, in that case, you would like to rule out pancreatitis or like, any kind of infection, because first of all, he is homeless. Second, they gave you a male, so you don't have to go for beta HCG. Third, they gave you an alcoholic. Alcoholic is one of the very common thing. And then fourth, they give you abdominal pain. So in this case, you would like to do what? Lipase or amylase, whatever it's available there. So you have to see what are the tests that you would like to do. In MCQs, they were not going to give you this. So you have to choose one thing out of all. Okay. So that's why you have to train your mind, particularly what they're looking for. Key test for specific diagnosis, so ALP, AST, and all these tests. Key test for OR preparation. So if you're going to do the operation, then CBC, electrolytes, creatinine. Even in OR, you have to see which one is major surgery, which one is minor surgeries. So in minor surgeries, we usually go for CBC, and I think that's more than enough. Like minor surgeries mean where you have to do a cut and then drainage of the pus, or let's suppose a dental surgery. That's all our minor surgeries. But when it comes to major surgeries like pelvic surgeries, if a patient is going for a hip replacement, if a patient going for knee replacement, in those cases we need to do the chest X-ray, ECG. That's what we order, like in our practice. Okay, so INR, PTT, choosing wisely does not recommend routine preoperative blood work for ambulatory elective surgery. As I said, elective surgeries, we don't do any blood work. We just only go for CBC. Although in other countries, we do a lot of things, but here in Canada, only CBC. Type of peritonitis: primary peritonitis, secondary peritonitis. So primary is basically where there is no etiology, and then secondary comes from the perfora and sorry, any viscera. Then tertiary comes from the secondary, which has been gone like even worse. Localization of the pain: where the pain is, you can see where the organs are there and what kind of pain they can present. So in kidneys, it comes, the pain is only on the flank area and going towards the lower abdomen, in the groin. Then ureter, ovaries, how does the pain presents, and then viscera. Even the pain presents and your main diagnosis is appendicitis, like patient is having right iliac fossa pain. So in the male, you can go for appendicitis, but in the female, you have to think about ovaries, you have to think of uterus, or you have to think of those things too. So, or PID. So it's more important, you have to see what kind of diagnosis you are making in male and female. So then differential diagnosis, you can just read this one. Referred pain, you can read this one. Most important presentation of surgical pain, just give it a read. Then most abdominal pain, so they gave the mnemonic about this one. The mass, you just need to know the differential diagnosis of this one, that's it. Then gastrointestinal bleeding, that's important. How you're going to approach a case, because the gastrointestinal bleeding, the upper GI bleed and lower GI bleed, both can present even in emergency, both in family medicine. We have seen a lot of cases in family practice too. So don't just limit it to the emergency medicine. So what happened in this one, it can come, so you don't need to know like the proximal to the ligament of Treitz and stuff like that. You just need to know how you're going to approach the case. If the patient comes with the bleeding, first of all, you have to confirm, is it bleeding or is it he mixing up with something else? Like let's suppose recently we saw a case, he was blowing his nose and he felt there is something like, redness coming out. But what happened is he was putting too much pressure, so that's why the blood was coming out. When he was not blowing, there is no active bleeding. So you need to know a lot of things through history. When they are giving you a case, you have to see how they are presenting the case. Initial management with the PPIs and endoscopy. If fail, then consider surgical management. Then lower GI bleed, we will read more about this one in the in the gastroenterology. Sorry, lower GI bleed is basically the one that's distal to that one, then it is basically proximal to the cervical and rarely melena. So when we are asking the case questions, then we ask, is it mixed with the poop? Is it separately? Is it fresh? Is it black? So those questions will be like, comes in that way. So mainly we go for endoscopy, and then you need to know the colonoscopy. Then in this case, now it's very important, you ask for cervical screening. Okay, so let's suppose if they ask you in MCQs a question like there is a patient with GI bleed and stuff, what is the main history question that you would like to ask? So asking for colonoscopy or a history of a cancer in the family, like colonoscopy in for him. But main important is history of cancer in his family, because we are ruling out colon cancer and it's very common in Canada. Then overt bleeding, obvious hemostasis and hematochezia. So you can read this one, occult bleeding. So it's basically that one. Differential diagnosis, blood works for the GI bleed. So mainly, okay, so sometimes a patient can come be like, oh, I have GI bleed, not GI bleed, like bleed, blood in vomiting, but it was one episode and I was at home. So in this case, how would you like to approach this case? Even it comes in an emergency. He's like, I had only one episode and it was too much. And he was just explaining to you, but you did not actually see it. So in that case, what you would like to do is CBC. Why CBC? We are going to do check for hemoglobin. In regards of hemoglobin, we can find out how much blood was lost. So doing a CBC is more important than actually finding out what is going on. So if they ask for what is the first line treatment, then go for CBC. But once the GI bleed is confirmed, then they says, oh yeah, you see the bleeding, there was 2 3 episodes, he has a picture and stuff like that. In this case, now the GI bleed is confirmed, now you can go for finding out the cause of GI bleed. But first thing first, if they gave you he has an episode but he's not sure and you are not sure, so CBC will help you to find out, yes, there was a bleed or there was no bleed. Then coagulation studies, blood type. Mostly we don't go for coagulation studies in many of the patient, because if there is no active bleed or there is no bleeding history, in those cases we don't go for PTI INR. Although it's very important to find out, but it's very less likely the patient's PTI INR will be deranged out of nowhere if he's not taking any warfarin or heparin or aspirin. In those cases we go for PTI INR. Biochemical signs of the differential diagnosis. So jaundice is basically, you can see. Then comes to the preoperative operation. It's important because it's also written in anesthesia chapter 2. So you can read it from there or you can read it from here. Both side, the preoperative preparation. Why is it important? Because of the medicine, which medicine you are going to stop, which medicine you have to start, how you are going to approach a case who is diabetic before pre-operation, how you're going to approach a case who is having low molecular weight heparin or any warfarin for so long, and how you're going to do the preparation for that case. So in MCQs, they do like to ask this kind of questions. So let's read this one. So consider the preoperative anesthesia, medical consult, and then NPO. According to the fasting guideline, then IV crystalloid or the maintenance fluid, and then always keep, if this is a major bleed, always keep the fresh blood in your hand. Appropriate use of the fluids preoperatively decrease risk of cardiorespiratory complications. Patient can take their, so if you go to anesthesia, you can find more about this one. So I would rather go to anesthesia and read this thing from there, but we can just read it quickly from here too. Appropriate use, and then patient can take their regular medications except for hypoglycemia, diuretics, and ACE inhibitors. Patient with a primary adrenal hyperplasia, what are you going to may require the additional corticosteroid stress dose, mainly giving steroid. Then anticoagulant, what are you going to do is how you're going to bridging them must be managed to decrease the surgical bleeding, but not put the patient to risk of increasing thrombotic event. Like bridging from warfarin, if patient is taking warfarin, it's very common in Canada. We usually give patient warfarin, and a lot of people are taking warfarin. Okay, so except for low molecular weight heparin and aspirin and diclorad, so we don't give these medicines here. Warfarin is given for the as a blood thinner, so you have to switch to low molecular weight heparin. Prophylactic antibiotics depending on the wound class, so cefazolin or the metronidazole. Then role of the MBP is basically consider the, so even when it comes to the skin wound, or if it's a contaminated wound, we usually start with amoxicillin, then go for any other. And we do cover it with the metronidazole in many of the cases, if it's a diabetic wound and stuff like that, to do the aerobics and anaerobes coverage as well. Most of MBP's incident is due to the MBP preoperatively and have no impact on postoperative complications. So this one is not a laparoscopic anterior laceration. So just read this one. Smoking, this one is very important. Smoking cessation and the weight loss preoperatively. Now the question can comes is patient does not want to stop. So in that cases, we try to counsel, we are going to document, patient did not stop. Now, if the patient is the emergency, the surgery is emergency, then we will proceed on with it. But if it's an elective surgery, we can always hold it, okay? In case of smoking. Can be decreased post-operatively infections, delay elective surgery with infection management. Even after the surgery, there is a lot of, when the patient is being discharged, we don't give antibiotics. It's followed by the family physician and antibiotics is given by him. When scheduling the surgeries from following the COVID-19, so it's all about PPE, you have to wear that one. In patient with the liver disease and acute abdomen, spontaneously bacterial peritonitis must be ruled out. So it's very important. Then you are going to ask the same history as we already discussed about this one. Best practice in the general surgery is basically resource from the quality improvement at the, okay. So here comes, so you can read this one, which one is the mild, moderate, and severe. So priority of the surgery. So if it's like on the basis of COVID-19, so you can just give it a read, okay? Then comes the investigation. What are the investigations? Knowing investigation, you can always write down, oh, I can do this, 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 this. Mainly which scenario you need to write on which investigation, that's important, okay? Then drains, we already discussed about NG and Foley's. So in the abdomen, don't forget the NGs and in obviously the Foley's as well. Then post-operative fever. So this is very, very, very important topic. Highlight it, read it over and over again and again. One of the most important topic. Okay, it can be asked in many ways. Be like asking for fever, how you're going to approach this case. If it's a quick fever, or if it's delayed fever. So in that case, the symptoms or signs is different and the diagnosis is different as well. Post-operative fever is considered as a the temperature higher than 38 on the 2 consecutive post-operative days. So fever does not necessarily imply infection, particularly in the first 24 to 48 hours post-operatively. So there is a question that can come if a patient just had a surgery and now he's having fever. This is basically a trauma fever. In that case, we don't need to give any antibiotics, anything like that. In that case, we just give patient some paracetamol, like Tylenol or whatever. Fever may not be present or may be blunted if the patient is receiving chemotherapy, glucocorticoids, or other immunosuppressive agents. Timing of the fever may help identify the cause. Very, very important. What is the timing? Hours after surgery, inflammatory reaction in response to the physiological stress from the surgery. So that's one of the important, like traumatic stress that happened. Most common cause of the fever on post-operative day 1 to 3, unlikely to be infectious. Even usually we say up to 24 hours if it's like that. So we usually go for this one. Reaction to the blood products received during surgery or malignant hyperthermia, like due to anesthesia, due to any of the drug, like, and it could be anything. So usually we write down, and they do like to ask you the diagnosis. So physiological stress. Then comes to 1 to 2 is acute atelectasis, early necrotizing fasciitis, wound infection, and then feel for crepitus and look for the dishwater drainage. What kind of drain is coming out? Aspiration pneumonitis and acute renal insufficiency. As you can see, this was said about 1 to 3, and this was said as 1 to 2. So usually the physiological stress is basically up to 24 hours. After 24 hours, we start looking for different things too. Okay. So atelectasis, like any necrotizing fasciitis or any aspiration pneumonia stuff, all these diagnoses. Then 3 to 7 is basically after 3. Now you can start thinking of infection like UTI because of Foley's catheter, surgical site infection, IV site, then septic thrombophlebitis, leakage at the bowel anastomosis or anything. Then more than 8 is basically intra-abdominal stress, DVT, and drug fever, other respiratory, seroma, myeloma, hematoma. Then resuscitation, then treat the primary cause. Then comes the wound and incision complication. This basically presented 2 to 3 days after epithelialization. So in this case, what you need to know is basically what could be the differential diagnosis of uh, the leakage or the fever. So they can ask about wound care. So did you check for the wound? What would you like to do after the, like, in your examination? So checking for the wound care and what are you going to see in the wound? So skin sutures and can be removed up to some exceptions. So negative pressure and then all. So you are going to check for fever, tachycardia, pain, checking for the granulation tissue. If this wound is smelly, foul smelly, or if there is any drainage, discharge, pain, any redness, these are all signs of infection. So we already discussed about the drains. So these are different drains that is placed in that one. So you don't need to know in that one. Surgical site infection. So in this one, surgical site infection is important in regards of tetanus as well. Okay. Uh, Surgical wound contamination. Mainly in surgical wound infection, you need to know what are the clean one. It's basically the hernia repair. The clean versus like or contaminated is basically, sorry, clean contaminated is basically routine cholecystectomy or colon resection. Contaminated is bowel obstruction with enterotomy and spillage of the contents. And dirty is basically the traumatic wound with the contamination and then uh, devitalize the tissue. So in secondary closure means leaving it open, and then primary closure, you know better how to do it. In this one, and then what could be the causes of this one? So age, diabetes, this can be asked in your MCQs too. Or what are the factors that could be the cause of the delay wound healing or contamination of the wound? Then you can read the prophylaxis because we discussed about the preoperative antibiotics. So you can read within 1 hour pre-incision. You can dose this one. You can with non-requiring for the low risk or the clean surgery improving to review and then redosing the antibiotics. Okay, and that's it. So from here on, what we were reading. So then comes to the treatment. Treatment is examination of the wound, as we said, what we are going to see in the wound. And main important, don't miss culture and sensitivity, especially when a patient with the wound presents in family practice and they would like to ask you what is the one investigation that you would like to do. Usually we go for CBC, checking for if he has infection or not. No, this culture and sensitivity of the wound, that's very, very important. Don't miss that one. Then reopen the wound and check for the drainage if there is, and then the necrotizing tissue, then cleaning the wound and giving antibiotics. Urinary retention, it's mainly we will do from the kidney chapter nephrology. So here, atelectasis, how atelectasis can present with an X-ray. Okay, so just see how the atelectasis X-ray looks like from the Google. Okay, and in this case, the most important preoperative complication that can cause the atelectasis is smoking. Okay, so they can ask you a scenario giving that the patient was counseled about smoking, but patient does not want to stop the smoking. Would you proceed with the surgery? Like based on the elective surgery, you can wait. If it's a emergency surgery, then you can proceed. And if it's an emergency surgery and you proceed, what kind of complication can happen? So atelectasis is one of the main common complication with this one. Okay. Now we are coming back to the intra-abdominal abscess. Although we in the intra-abdominal abscess, usually a patient presentation, like in our up to our like level, we just need to know how can it present, like clinical features of that one. Like the drainage and everything is going to be done by a gastroenterologist. So just knowing how it's going to present, manifest at 5 to day after surgery. So it will present mainly after the surgery. Okay, so even giving you this one, this can give you a lot of idea about it's an intra-abdominal abscess going on. Then comes to surgery. It's just mainly the mass part. You don't need to know a lot of cancers or T3s or the staging of the cancer because that's not our level. So just doing chest X-ray, finding out why are we doing X-ray if a patient has cancer in the abdomen to find out the mets. Okay. So they can ask you if the patient is having this whatever cancer going on and now he's presenting with the difficulty breathing, shortness of breath. Don't think of asthma. Okay, so think of chest X-ray, doing of X-ray. Maybe it's there is meds in the X-ray you can find out. Okay, done. Although in the MCC objectives, it's written the lung cancer, where like in the if you go, they say is the mass part, like abdominal mass. In that one, there is like cancer part. All you need to know is just investigation and which investigation, and that's about it. Because in the other part for the treatment, we are not going to do anything. It's only the oncologist, the gastroenterologist, those are the one that will take the case on. So in your case or in your level, you just need to know the investigation part. Or they don't ask you for complicated surgery type names, like what are the surgeries you would like to do. Only the basic main surgeries that you need to know. Complicated paraneumotic confusion emphysema. So starting like coming to emphysema, it's basically a continuous spread from the lung infection. So you are going to do the CT scan, not the chest X-ray. Then comes to the pneumothorax. We already did that in the, and it's also one of the complication of after the surgery as well. There's no need to do the lung transplantation. COPD we'll do from respirology when we'll do the asthma as well. Then comes to the mediastinal masses. Usually it's not very common, but they can give you an X-ray and then can ask you for this one, what is the diagnosis? And in the X-ray, it's very common that you can see the mediastinal masses. Which one? Thymoma, thyroid enlargement, teratoma, and the tumors, mainly of the mediastinal tumors. Uh, and then you can usually we do X-rays to compare from the previous X-rays. That's about it. And that treatment is Xen anyway. Then comes the esophageal perforation. Why we are doing this one? Because it can also present with the upper GI bleed. So, Borheav's syndrome, transmural perforation, and Melritt-Wiestiers when there is non-transmural perforations, and then both can present with a forceful emesis. So, in this case, chest X-ray, CT scan with oral. So, usually starting with chest X-ray, looking for subcutaneous emphysema, pneumothorax, pneumomediastinum. So, usually with the case tree we do get the diagnosis, but in this case we're still doing the x-rays. Okay, so it's not a clinical diagnosis. Then comes as an emergency physician you are going to start with a smooth sportive if ruptured is contained. Now if an upper GI bleed can present in family practice, in that case you are going to refer that patient to emergency medicine. There was recently we saw a case with having abdominal pain and we listened to his bowel sounds and there is no bowel sounds. So we're thinking of obstruction and we referred that case right away because we were working in emergency. Sorry, working in family like clinic. So we referred that case to emergency. So if they are giving you some sort of tricky scenarios where you are sitting in an emergency and you feel like it's an emergency case, you can always refer that case. And in MCQs, they give you an option of referring the case too. Now, NPO, so surgical, it's very important when you are going to plan for the surgery because it means that you are thinking of calling a gastroenterologist. Surgical is basically less than 24 from perforations and more than 24 from perforations. So this can be asked. Don't think of this as a case of gastroenterologist. It is mainly you who is going to decide or hand over the case to the gastroenterologist. Although you call it, but you should be aware of at which level he needs an operation right away. So surgery is basically 24 less than 24 hour from perforation, mainly closure to a healthy esophagus and all that, and more than 24-hour perforation with the diversion and then exclusion. So especially in abdomen, your like when you are thinking of going to take the next step, it's very, very important. 6CS of the squamous cell carcinomas is basically smoking spirits, seeds and scalding, strictures, and sac. Just the pictures, and there is one thing here. Why I don't miss this one? Because I saw one of the MCQs in MCC objective, not objectives, the MCC practice test. Here. Like one of this can cause vitamin B12 deficiency. I'm not sure which one is it. I think sliding is basically majority esophagitis and investigation, surgical, 24-hour esophagram study. So just show you. So just look into that one. I am not sure. I just want to give you the wrong idea. So there is one of this one that cause vitamin B12 deficiency here. So it's I think this one, ferrous deficiency, and then one cause vitamin B12 as well. So look into that one. So mixed which causes the Fe deficiency anemia. So it's this one they can ask you in questions like giving you a hernia case and giving you like iron deficiency and now asking you to make a diagnosis. Now you know if you have read it thoroughly, now you know this is the mixed hiatus hernia or is this something else. If you haven't read it, even you can see it from here. Fe deficiency anemia is basically the paraesophageal hiatus hernia. But if you have read it thoroughly, what is the difference between the two? Then you will be able to select from the cases which one is it. That's why I'm saying there's little bit few lines that you need to know and what are the complications. So this is basically the complication of that one. So it's having for prolonged period of time he was having the symptoms, now he's presenting and you did some tests and it says Fe iron deficiency anemia. What are the diagnosis? So if you know iron deficiency anemia is presenting in which type of hernia, then you will be able to do it right away. Then the mixed most common type of the surgical repair, so reincidents and then may present with the long standing. So it says may present, but this can cause basically in the paraesophageal. But treatment is basically surgery, so that's going to be done by some anyone surgeon. Achalasia, just know how does the X-ray of achalasia look like or the barium study look like. and the complication esophageal. I would suggest when you're reading the thoracic surgery or any topic, don't forget about complications. There's a lot of people just present with complications. They don't even have any signs and symptoms. Okay. Okay, peptic ulcer disease, it's very, very important. And then it's mainly written in the gastroenterology. We'll definitely do it from there. Here, it's mainly how you are going to approach the case as an surgeon. So it's not our thing. Although you can read the complications of gastric surgery is retained antrum, diff fistula, and dumping syndrome. Dumping syndrome is very, very, very important. And there is, I think in MCC objective, they give you some questions being giving that there is that case that patient has done a gastric surgery, now presenting with sign and symptoms, and the answer is gas dumping syndrome. And you can just read this table as well. Just forget about other thing, then you can just read this one. How you're going to approach the perforated ulcer, just read the management. Penetrating to nearby organs, you can read the management. Hemorrhage, you are going to start with the resuscitation, diagnosis, intervention radiology like angiography, and then go for surgery. So that's going to be done. Then outlet obstruction, basically putting NG tube. So in outlet, any kind of obstructions coming to the abdomen, NG tube is one of the most important one. Then you can forget about these extra tumors. The bariatric surgery, there is something here. The complications, okay. The complications for the laparoscopic one, the complications for the restrictive laparoscopic one, and what is the name of this one? I think this one, the name is important too. So the MCQs would be like gastric bypass, ROX and Y gastric bypass, laparoscopic gastric bypass. So if you don't know the name, sometimes this kind of confusing questions can come. And yeah, so this one here, complication of the gastric surgery. This is very, very important. Alkaline reflux gastritis, how it's going to be presenting is basically the gastritis presentation after the surgery. And the treatment, how you're going to approach. So starting with H2 blockers, afferent loop syndrome, accumulation of the bile and the pancreatic secretions. The clinical feature is basically postprandial distension and all this right upper quadrant, nausea, bilious vomiting, then treatment is surgery. They would like you to do the diagnosis. They will give you a scenario and then you have to make the diagnosis. If you don't know the diagnosis, then it would be hard for you. Then dumping syndrome, it's very, very, very important. Postprandial epigastric cramping, blotting, MSA nausea. Then how's the treatment is basically treatment. Why it's important? Because of the treatment. There is no medicine, no surgery, only advising about frequent small meal high in fiber and protein, low in carbohydrate, avoidance of the liquid in meal. So lots result in interposition of the junction. So usually we go for this treatment. So they like you to ask how, if you know the basic counseling part, how you're going to approach the case or what you're going to tell the patient. And then this one, hypoglycemia following the postprandial insulin peak. Okay. So then blind loop syndrome is basically uh, antibiotics. You have to give the antibiotics. I hope I'm not making things complicated for you. I'm giving you things from which you have to read. So don't read everything like regardlessly. Just read the important things how I told you. So the complication part, some investigations, like if there is any investigation written, this is the gold standard or this is the one investigation you would like to do to make the diagnosis, what is the important signs to make the diagnosis. So those are the things that you have to pick from here, especially from general surgery. You are not a surgeon, you are just a family physician or an emergency physician. So your main thing is making diagnosis, doing one investigation, calling for surgeon. That's about it. So don't complicate yourself making things hard, like memorizing